Hi, Chastity.
Hi, Sarah.
It's good to see you.
Thank you. It's great to be here.
Thank you for joining us for this episode of Thrive with Us. I'm really excited to talk to you about something I know we've discussed in the past, which is mental health and the role of social media in information, misinformation, disinformation, the
Mm.
complexities of diagnoses, and a lot of other stuff. Before we get into our discussion for today, I just want to quickly introduce you to our audience who may not be familiar with you already. So I'm sitting here today with Dr. Chastity O'Connell, who has been with us at Thrive since August 2021. Dr. Chastity is with us as a psychologist, CDA licensed. She's also a professor of practice at the American University of Sharjah, and she's held a number of roles at Thrive, including clinical advising director and the head of our early career professional program. The work that she does is varied. She sees people of all ages, but tends to focus on adolescents, adults, can also work with couples and families. And I could go on and on and on. But I'm really excited to be here with you, Chastity, today. Thank you again for joining us.
Thank you. And what a warm and lovely introduction. And it's been a really fantastic journey at Thrive. So happy to be a part of it.
Yeah, it's been awesome having you. And I'm really excited to have this conversation because I know that you and I have talked about it quite a lot.
Yes.
On a personal level, just kind of between the two of us, and then also on a more professional level. So our episode today is called Not Everyone's a Narcissist. And you and I went back and forth a little bit before deciding on this title. And the reason that we chose it is because we know that this term, along with many others like gaslighting, OCD, et cetera, are being thrown around. And people don't quite understand what it means and are putting those labels on themselves and other people, and that can have some ripple effects. So it would be really helpful for us today to clarify, what do these things actually mean and what does the diagnostic process look like?
So, as you mentioned, one of the areas that I support Thrive is in the area of clinical supervision and clinical consultation. And there's some interesting trends that are going on with the clients that are coming in through the door. And clinicians regularly point out that they know so much more. They've done a lot of research. They've listened to different influencers. They've listened to different podcasts and YouTube. So there's a lot that people already understand or think they understand about themselves when they come in the door. And there's some really big terms that are getting tossed around.
Yes.
And for folks outside of psychology, terms like narcissist or borderline or autism don't have the heft or meaningfulness or seriousness as they do for licensed clinicians that are responsible for helping people understand and navigate these different experiences that people have. So part of our work is on psychoeducation and even working to dismantle some of their understandings on these different, really big, very impactful disorders or phenomenon or concepts that people might be tossing around when they come in the door. And why does this matter? And so I think one of the key issues that comes up in sort of navigating this abundance of information is what invariably happens, which is a kind of misuse or misunderstanding that happens in these key diagnostic criteria. So let me give you an example. Let's say you and I are having a coffee out somewhere, and I say, you know what, Sarah, I'm feeling kind of tired. We're like really tired. I noticed that my stomach's hurting a lot. I'm not really eating that much. I've been losing weight and I'm tired, but I'm not sleeping well, but I'm having like these abdominal pains. I'm not sure what's going on. And so imagine you say to me, well, gosh, weight loss, abdominal pains, fatigue, gosh, that might be pancreatic cancer.
Mm-hmm.
Now, that would be extremely, I don't even know the words, dysregulating, upsetting, completely out of proportion to what might be going on. It might just be, I have a gluten intolerance.
Yep.
But because there is such an abundance of information, and the way we ask questions and the way the internet feeds us with this information, or the way the algorithms work in bringing information to our door, we have a variety of cognitive biases that get activated when we think about that. Now, I think anyone listening would agree that that would be extremely unhelpful to suggest that you would suggest that I have pancreatic cancer, where we're finding the same kind of phenomenon going on with mental health terminology and some of the big ones: narcissism, borderline, autism, ADHD. And so, and I think where this comes from is a lack of knowledge and understanding around the clarity of the diagnostic process. Now, one of the things that might distinguish something from pancreatic cancer, and I am not a medical doctor, is that the terms that you would use are really far removed from your average person's lexicon, right? So we're not familiar with it. They might have hemoglobin or some other words that we just don't know what that means. But if you're looking at the diagnostic criteria of something like narcissism or borderline personality disorder, they're really accessible. And not only that, they exist outside of psychology.
Yes.
So what's some of the terms we hear in Dubai, like, oh, they're so entitled, or oh, they're selfish, or have you no empathy? In a sort of common language speak, we know what those terms mean. But in a clinical perspective, when we see those terms, they mean something very different. And I think most people, well, I know most people don't know what clinical training enables us to do to distinguish the difference between a sort of common language understanding of, say, depression and a clinical diagnosable condition. And so one of the things I'd like to share with people is how we kind of go about diagnosing, like demystifying the process. And so with something like narcissism, it's important to note that narcissism is not a disorder. It's a trait. And there are many traits, and traits have a spectrum. And you can have a healthy level of narcissism. And I think that's really surprising for people. You can also have an unhealthy level of narcissism where it's problematic, but maybe not what most people are misattributing as narcissistic personality disorder. That's when that spectrum goes into a place where they are hurting others. There's dysfunction, there's distress, and it brings up one sort of quick heuristic that we use sometimes to understand whether something is clinically relevant or a healthy but unpleasant phenomenon, are what we call the 5 Ds. And the 5 Ds stand for dysfunction, so the level of dysfunction that a person may experience as part of that disorder. Distress, how distressing is it? If it's mild, then we might be talking about over here. If it's moderate to severe, then we might be talking about something that's in the clinical realm. And the distress, and this is what's interesting for some of our personality disorders, these are our more deep, really pervasive disorders, is that distress can sometimes not be nested within the person. It's how they impact other people.
Yes.
So you probably heard of the term narcissistic abuse. Maybe the person that has these narcissistic qualities or a narcissistic personality disorder may not be experiencing that distress, but they're causing it on other people.
Yes.
So that's 2, distress. Danger. What level of danger could the person be experiencing, either to themselves or to other people?
Okay.
Deviation. Is it, where does it fit within the range of what would be expected within your normal human experience? How long has this been going on? Is it something that is kind of temporary, or it's for a period of time, or is it something that's existed through the lifespan?
Mm-hmm.
And these are shortcuts, and they give you kind of a window into how much nuance, how much evaluation, clinical evaluation is involved in the understanding of these disorders. And that's only the tip of the iceberg. What they mean in psychology is something different. So even with something like narcissism, for example, are we talking about a trait, and is it in a healthy amount? Or are we looking at something that involves much more extensive criteria? And even when we're looking at some of the criteria for narcissistic personality disorder, those again are really, those are words that we're exposed to, words that we're familiar with. So for example, grandiosity or level of self-importance. We've heard that. We've used that term. Oh my gosh, we have a supermarket called Grandiose. And so when, people see that, it's really easy to fill in your own non-clinical understanding of what that might mean. Selfishness, lack of empathy, power, need for admiration. Again, these are really not clinical or fancy
Not very
terms.
technical terms. No.
Thank you. Yeah, not really technical terms. And so it's understanding why people would look at that and ascribe those to other people.
They feel when they see it, unlike a medical issue or condition, that they can understand what the criteria mean, and therefore it's much easier to screen and say, yes, this applies, yes, it doesn't apply. What I'm understanding from you, and I've also heard the same, is this means that people are experiencing or anticipating or suspecting much higher occurrence and prevalence of these conditions than actually exists. And what you were sharing, which I think is a really helpful point for people watching this, is that there is a difference between a trait, a characteristic, and a disorder. And I'll share with you something, and with our audience as well, because this is something I used to tell my students when I used to lecture also. OCD is another one of those labels. Sharing something from my own personal history, when I was a kid, and even until now, if I'm honest, if you open my closet, it is something else. All my hangers hang in the same direction. The labels hang in the same direction. I go in color coded. I go from lightest to darkest, from solid to print. That is my way of finding organization and being able to be like, I want a black dress. Okay, well, here are the sleeveless, here are the blah, blah, blah. Now, people can call me OCD. And in fact, that term has been used. But if we go through the 5Ds, none of them apply. I'm not staying home and missing out on social opportunities or work opportunities or anything like that because I'm busy organizing and reorganizing. If there is a deviation from the order, let's say someone put something in the wrong place, and I'm not so happy, but it's not turning my life upside down. Absolutely. And so I think the thing is we look and we see like one expression of something that we think is an indication of something like OCD or narcissism that has heft, as you mentioned earlier. We extrapolate and generalize that to you must be suffering or struggling with this condition. And that's just simply not the case.
Absolutely. I appreciate so much you sharing that example, because you're right. If we apply the 5Ds, there isn't danger. There's, maybe some discomfort when things are disorganized, but it's not distress. Like you said, it's not causing a level of dysfunction. It's not preventing you from living your life. And in fact, if we looked at just, one of my favorite sort of ways of understanding and categorizing personality is called the Big Five. And these are neuroticism, openness, conscientiousness, agreeableness, and extroversion. Oh my gosh, how could I forget extroversion? And so this would say that we have a number of different personality characteristics along different ranges, and maybe you might be higher on conscientiousness. And that is self-knowledge that can be helpful. But again, it's not falling within that OCD realm. When we misuse these words, we're doing a number of things. First, we may be applying something to ourselves that may be at best unhelpful or harmful.
Mm-hmm.
Number two, we're also denying people who are really seriously
Mm-hmm.
affected by these diagnoses in extremely meaningful ways.
Mm-hmm.
And so we're denying the sort of severity and impactfulness of their experience. And we're also sort of foreclosing
Mm-hmm.
on a self-discovery process, on a self-understanding process. I mean, as part of the challenge is that, we love our heuristics, we love our mental shortcuts.
Mm-hmm.
We do have cognitive biases that are active and how we sort of try and understand the world. But we know more than anything, what's really beneficial is to allow space for that process and understanding and acceptance or even appreciation for how that works.
You were mentioning at the beginning of our conversation is that people are coming into therapy armed with much more knowledge, which can be a really good thing in some ways. So they might recognize that something's a little bit off, maybe a symptom or two and like one or more of the D's, and then they start searching and then they uncover some checklist somewhere about how to tell if you or someone you love is a narcissist. And then they come into the clinic. So in some ways, they have that awareness and insight that led them to search for that information. But depending on the information and then the conviction that they have with that information, it seems like you're saying it can sometimes inhibit them from that introspection and insight awareness building process, which is very, very needed when it comes to making gains in the psychotherapeutic space.
Absolutely. And so that's part of our work is psychoeducation and helping people understand themselves. And one of the things I think that's also going back to the diagnostic process, in addition to our 5Ds, and in reality, that's not even the tip of the iceberg. That's like a snowflake brewing somewhere off the coast of Antarctica that's going to land on that iceberg. But I would be remiss if I didn't discuss how much their symptom overlap is or can be with certain diagnoses. So, for example, if we're looking at narcissistic personality disorder, there's a symptom profile or symptom overlap that could also make it look like ADHD, could also make it look like autism. Now, I want to be really clear. These are very different, and I don't want to say that there's anything in common, the underlying mechanisms. But if you were to look at something like ADHD, for example, and there is inattentiveness, there's impulsivity. So you might see it as someone talking about themselves, blurting out things, forgetting things. If we look at narcissism, you could look at that person and say, gosh, they're so selfish. They only think about themselves. They don't really care about me. They're, always letting me down. They must be a narcissist. Autism is another one. Oh, they lack empathy. They don't have, they are fixated on themselves. They don't ask me questions about myself. And I'm not even capturing the sort of real severity of narcissistic personality disorder, but I'm phrasing it in a way to, sort of speak to this common language aspect. You might misdiagnose or misunderstand someone that might have traits of autism or autism spectrum disorder. So there's really so much at stake when we're tossing these terms around, which is why discussions like this around helping people question, because we also know, again, I was talking about cognitive biases, like something like the Dunning-Kruger effect. I don't know if you're familiar with it, but this basically says that, we tend to be overconfident in what we think we know.
Yes.
And again, if we look at the language, the criteria, it's all commonplace language, does not mean the same thing. When we unpack those diagnoses, we know what that actually means and what that needs to look like to qualify. But for many people, they see that entitlement or grandiosity and they're like, that's my husband, or that's my uncle. And unfortunately, it can really have some deep and unhelpful consequences on people's relationships.
I'm thinking back to the example that you gave at the beginning of our conversation about sharing symptoms and then me telling you it sounds like pancreatic cancer. As you were going through the list of symptoms, there were many dozens of different things that, came to my mind that it could be, including some of them are symptoms of depression, some of them are symptoms of anxiety, some of them are symptoms of
Absolutely.
pregnancy,
Yeah.
all sorts of things. And so what I'm hearing from you, and I think it's really important to underscore, is that it's not just a collection of symptoms, because the same symptoms can be relevant and applicable to so many different traits and disorders.
Yes.
And what we need to do as clinicians is go through a thorough diagnostic process to rule things in and to rule things out. So walk me through what that process would look like. Let's say I come to you as a client and I say, going with our narcissistic example, I'm going to use the language because most people come in with that language already. I'm noticing I don't have a lot of empathy for people. I am fixated on achievement and power. And people are always telling me that I'm like super selfish. I think I'm a narcissist. What do you do with that?
Oh, that hits close to home. Many people do come into therapy
Yes.
and share this really pain. And that's such a great point, because there's a lot of distress. Like they see these symptoms and they think that that could be me. In fact, there's a phenomenon called medical student syndrome, and the same thing happens in psychology. You read through the criteria and you think, oh my gosh,
I have it all.
I have it all. And so your question about what actually happens, I love it, because I do think, and this is a critique of psychology as well, I do think there's not often and not as much transparency as there could and should be with the diagnostic process. I'm going to ask you this, and this is what I'm trying to understand. Then we're going to look at this, and then we're going to talk about this.
Yes.
So not a lot of transparency. So this is an exciting opportunity to kind of go through that. And I might refer back to those 5 Ds. We wouldn't necessarily do that in a clinical consult because there's so much more going on beyond the 5 Ds. But you'll hear me refer back to them just so the folks at home can anchor to what this would look like. So the most important thing from the beginning is to build rapport. Compassion and understanding. Why? Because the quality of our diagnosis depends on the information provided. And so if people are coming in and feeling judged or feeling ashamed, it might take some time to establish the level of trust that's going to lead us to a really clear diagnosis. And oftentimes we do something called a provisional diagnosis. The rule-ins, a differential diagnosis, which means, so we hypothesize with what we might be working on or what might be occurring for the person. And the differential is exactly what you were talking about when you were saying these could be symptoms of depression. It could be symptoms of anxiety. It could be pregnancy. We list those. We should be listing those things and saying, well, let's rule this out. Let's make sure it's not this. And those lists can be pretty long. And so we start with a hypothesis, and the rest is data collection. And that sounds really, when I say it out loud, it's a factual process, but it looks very human-oriented, very compassionate, and it's about understanding you as a person and what has brought you up to this point so far. And so if I'm thinking about the diagnostic process, I'm referring back to one of the 5 Ds. We have duration. So one of the things is, how long has this been going on for you? And if you tell me, oh, it's been going on for 2 to 3 months, that is really important in our rule in or rule out process. If you say, I've been feeling this for most of my life, that might bump up one of our differentials to our provisional. And that lets us know that we might be talking about something more involved. And so through the process of understanding your history and asking a little bit about what's been going on for you now, when did you see those changes? Um, have there been times in your life where this has happened before? And certainly exploring things like trauma or adverse experiences are going to help us contextualize or help us understand what symptoms are relevant and what aren't. Because we as diagnosticians, as clinicians, we need to separate the signal from the noise. And not everybody that has a trauma history will have symptoms that present as trauma, although they might say that. And yes, that might play some kind of role. But we need to understand, again, that in context, how did it take shape? And of course, there's also the process. There are different things like assessments on personality or psychoeducation, which could also give, it's a sort of time-limited process that can give a ton of information around self-knowledge and self-understanding that can help people and help the clinician understand what might be going on. But really, it's about a very thorough, and it can be structured or it can be semi-structured or informal process. Now, for many folks, when we're talking about the personality disorders, and that's where narcissism falls under, it's a personality disorder. That takes a level of clinical competence, skill, experience to be able to diagnose that accurately. And unfortunately, many clinicians, and this is not to disparage clinicians, I'll explain why this is, many clinicians don't have a ton of experience with something like narcissistic personality disorder. Why is that? They don't tend to come into therapy. Where we see them most is in couples work, and sometimes in our prison populations, or if they've been partner requested to show up to therapy. So that level of competence and understanding, what that criteria mean, what it actually looks like in people is really important. So that can take, if we're talking personality disorder, a number of sessions to unfold and understand. But again, that process in and of itself is also deeply beneficial. So it's not like I think to compare and contrast the medical model from this sort of clinical psychology model. The medical model, you would go in to see your doctor, they look at symptoms, they maybe order tests. Hopefully those tests give some kind of conclusiveness around what might be going on. But the kind of potential to drill down to what's going on can happen a lot more rapidly. I think of things like strep or other, viral and bacterial things that go around.
Yes.
But to manage expectations for people, that process for clinical psychology can take some time. At the same time, if you have any questions, concerns, or worries about the process, please, I encourage you to really talk to your clinician and draw them in and let them know that you want to know how this is happening or what's going on with your process.
Yeah. One of the things you shared at the beginning is this idea of building rapport. And what we know is that the therapeutic alliance, the bond between the clinician and the client, is really, really important and impactful on the process and on the outcomes. At the end of the day, when people come, whether they're coming to see us in the context of couples therapy, individual therapy, family therapy, assessments, whatever, they are discussing history, background, things that are very difficult sometimes, often things that they've never disclosed or shared with anyone. And so a big part of it is making them feel that this is a safe space. You can trust me. And that takes time. It's hard to walk in a room and be like, hey, stranger, here you go, and just dump that information. So it is definitely critical. And then what I'm hearing from you is that it takes time to gather that information and to start to figure out what we might be working with. It could be all of these things. So let me make sure it's not this. Let me see if it's likely to be this. And then it's like an iterative process until you get somewhere. And I think it's very important for people to know that, yes, it might take time, which is an investment of multiple resources, but it's the foundation for the treatment, right?
Absolutely. Absolutely. When we look at the research on what makes therapy
Mhm.
effective, the overwhelming majority is the quality of the therapeutic alliance.
Mhm.
And so I think sometimes, especially in a place like Dubai, I was mentioning earlier, context matters.
Mhm.
And in Dubai, we are so looked after when it comes to convenience. We
Mhm.
get things quickly, we
Mhm.
get things beautifully packaged. We have high expectations. And I think there is a contrast between those high expectations and what you get in all areas of your life. And when you come into therapy, where it takes time for things to unfold. And it
Mhm.
really is exactly as you were framing it, that, for people to trust us, for people to share, to collect that information that's going to help us understand what might be going on, definitely takes time.
Mhm. It does. And so we talked a little bit about what the process looks like. We talked about the criteria. We talked about how the language and the availability of that information might increase the likelihood that people are going to overdiagnose. And we also talked about when something might be moving from the space of like trait level into a disorder level.
Mhm,
And that a big part of that was the 5 Ds.
mhm.
So for anyone out there watching this right now who is convinced that they or someone they know is a narcissist or is OCD or is autistic or does have ADHD, what would you say would be the next step?
Well, the next step, we know that mental health is incredibly, critically important.
Mhm.
And we have been fighting for parity with the medical profession. So if someone was really struggling with a collection of physiological symptoms,
Mhm.
we would say you should go see your doctor.
Mhm.
And there's no reason why we wouldn't want to recommend that for mental health, especially if we're talking about big name diagnoses. Um, because really it can be very damaging. A lot of people self-diagnose, and in this self-diagnosis process, it can be, like I said, unhelpful at best and damaging at worst. And
Mhm.
I think one of the things I didn't share with the diagnostic process is the outcome.
Mhm.
So very rarely, well, okay, I shouldn't say very rarely, but it isn't often that we have straightforward cases.
Mhm.
You might be working with someone and say, okay, what I thought was major depressive disorder actually is dysthymia or
Mhm.
persistent depressive disorder. But because it's been going on for so long, there's some other traits that might understand your difficulty with relationships and some of the frustration you might be experiencing at work.
Mhm.
And here are some of the traits that you're also
Mhm.
experiencing. Again, it's not a full diagnosis of some kind of personality disorder, for example, but it's a comprehensive and enriched understanding of the person so they can come away from that going, oh my gosh, I can't believe I came in here thinking I had borderline personality
Yes.
disorder. I really have persistent depressive disorder. And I have some traits that kind of cause this interaction effect, this ricocheting and amplification of the psychological distress I'm experiencing.
Mhm.
And let's going back to the narcissistic example. Someone comes in and they're like, I think I might be a narcissist. It's like, well, let's look at that. And what can ultimately, or what might eventually unfold, is that there is a lot of vulnerability, shame, over responsibility.
Mhm.
And that might come from early childhood experiences where they had to be
Mhm.
responsible for caretaking the emotions of the family.
Yes.
They were the parentified child.
Mhm.
And so, what they're doing in their relationship now with someone who probably has some difficult traits, they are reenacting the same
Mhm.
thing. They are absorbing some of those problematic traits. And because they're so close to it, they're struggling with discerning what's mine
Mhm.
and what's theirs.
Mhm.
So, those are just two snippets. So, your question about,
What do we do?
what do we do?
Yeah.
I wanted to offer like two really kind of user-friendly, accessible windows on how therapy can really help clarify and going up beyond diagnosis. Diagnosis is just there for us to help understand how
The
to form a
frame. Yeah.
treatment plan.
Mm-hmm.
Ultimately, the clinical picture is so much more complex, and that's a good thing.
Mm-hmm. So what I understand from you is if someone is out there thinking this about themselves or someone else, the recommendation would be to talk to someone. And I think that makes a lot of sense for all the reasons that you shared. And that with a qualified professional can kind of figure out what's going on and also how it's impacting. Because the alternative, I think, is if they don't, they carry the label around with them, which can have a number of consequences on self-esteem and self-concept, and that can kind of spill over into other things. But also, if they are carrying around that label for someone else, as you mentioned at the beginning of our conversation, it can also be weaponized, right? And that can then have cascading effects into that person's self-esteem. It's just very complex, as you said, as we humans tend to be. Diana yesterday said we're beautifully complex. I like that.
Yeah.
But ultimately, in a nutshell, if we can summarize what our discussion was today, I think there are a few key takeaways, right? Number one is not everyone's a narcissist. If everyone we thought was a narcissist was actually a narcissist, we'd be living in a world full of narcissists. And the prevalence of narcissistic personality disorder it's just not that high.
No, it's low. It's surprisingly low. Surprisingly low. Now, do we have people with narcissistic traits? Yes. Do we have people that are kind of jerks sometimes? Yes, we do. And Dr. Ramani, who is just a fantastic expert on narcissism, does some really great YouTubes and podcasts on distinguishing between a jerk and a narcissist. And she says all jerks or all narcissists are jerks, but not all jerks are narcissists.
Makes sense.
And I think if we can hold that, then we can also forgive ourselves for those moments when we do act selfish and entitled and in our own best interest, which happens to all of us at some point in our lives. So we can forgive ourselves.
Yeah.
But there is a qualitative and a clinical difference between sort of that narcissistic trait, which is part of our personality structure, between those situations that kind of trigger us and evoke our ugly side. Now, that's not to say it's the situation's fault necessarily. That is how we respond to it. No, the only exception I would say to that are in abusive relationships. That's something different altogether. But if we lose it in traffic, we lose it because the delivery guy gets our order wrong, that's on us on how we respond. And then there's the disorder. So it's big, huge from psychologists, big, huge differences. But for I think your folks out there, it'd be impossible to distinguish the difference.
Impossible. And so if you are suspecting that this is something that you or someone you know is struggling with, or that something just doesn't feel right, a good first step would be to meet with a qualified clinician who can form a relationship with you, that therapeutic alliance and bond, build that rapport, that trust, that safety, to gather the information and help you figure out what's going on so that whatever treatment is indicated is most likely to be successful. And that's an intense process.
That's right. Yeah, absolutely. But worth it.
Definitely.
But worth it.
Definitely. Thank you so much for your time, Chastity. It was a great pleasure, as always, chatting with you about this very important topic. As I mentioned at the beginning of this episode, you've been with us at Thrive since August 2021. And if anyone wants to get in touch with you, they can find you with us at Thrive. Thanks again for your time.
Great. Thank you so much.